Hello everyone. Today we are going to discuss about the acid-base disorder. It was also the question which was asked in DRNB critical care exam in October 2023. So the question was non-NN-gap metabolic acidosis causes and diagnostic work. So acidosis is the pathophysiological process that may account for decrease in the blood pH that defines acidity. The two main mechanisms that may be responsible, that is a decrease in plasma bicarbonate defining metabolic acidosis and increase in PaCO2 defining respiratory acidosis. So in case of metabolic acidosis, the decrease in plasma bicarbonate either reflects the intervention of buffer system related to accumulation of non-respiratory acid and excessive loss of bicarbonate. So formula for compensation. So blood pH can be kept normal through decrease in PaCO2 obtained by compensatory hyperventilation. So acidemia occurs when respiratory compensation is insufficient. So PaCO2 values that maintains the normal pH called the expected PaCO2 and can be calculated using the formula. That is expected PaCO2 is equal to 1.5 into bicarb minus 8 plus or minus 2. So next step. So if we diagnosed it as metabolic acidosis, then to know the further cause, we need to know what is ANAN gap. So ANAN gap for corrected albumin should be probably be used rather than the uncorrected ANAN gap. So what is adjusted ANAN gap is? So adjusted ANAN gap is ANAN gap major plus 2.5 minus 4 minus albumin. ANAN gap is calculated as sodium minus chloride plus bicarb or sodium plus potassium minus chloride plus bicarb. And the normal range is between 12 to 60. So so our next step is to calculate delta ratio. So why the calculation of the delta ratio is important? To know whether it is isolated ANAN gap or whether there is a component of metabolic acidosis, metabolic alkalosis is also there. So to calculate delta ratio, we need to know the ANAN gap adjusted minus ANAN gap normal upon HCO3 normal minus HCO3 major. So if this delta ratio is 1, then there is only high ANAN gap metabolic acidosis. If this delta ratio is less than 1, then additional non-ANAN gap metabolic acidosis is there. If the delta ratio is more than 1, then it is additional metabolic alkalosis. So if it is lower than the expected range, then the elevated gap metabolic acidosis plus normal gap metabolic acidosis is there. If it is within the normal range, then only elevated gap metabolic acidosis is there. If it is higher than the metabolic, if it is higher than expected range, then there is a elevated gap metabolic acidosis plus metabolic alkalosis. Now the next step is to calculate osmolar gap. So for calculation of the osmolar gap, we should know what is serum osmolarity. To calculate serum osmolarity, the formula is 2 into sodium plus B1 upon 2.8 plus glucose upon 8. And the osmolar gap formula is measured osmolarity minus calculated osmolarity. So if this osmolar gap is more than 20, then there is a presence of toxic alcohol. Now after calculating everything, after knowing ANAN gap, delta ratio and osmolar gap, now we will see how to interpret high ANAN gap metabolic acidosis. So if we'll find our ANAN gap is elevated and if it is metabolic acidosis, then we need to check the levels of the lactate and the ketones. If the lactates are high, then we need to find out the cause of it. So the lactates are high. The cause of high lactate is maybe because of systemic cause and maybe because of the regional cause. Systemic cause could be anything like any kind of septic shock or cardiogenic shock, or there could be the regional cause behind it, like bowel mesenteric ischemia or limb ischemia. So if it is none, then then it could be because of the side effect of medicine, toxic ingestion, and malignancy. So if the ketones are high, then check the level of the glucose. If glucose level is high, consider the diagnosis like diabetic ketoacidosis. And if ethyl glycol, if the alcohol level is high, then the consider the cause like alcoholic ketoacidosis. Then check for the renal function. If lactate and ketones are normal, then check for the renal function. If renal function is abnormal, GFR is less than 40, anion gap is less than 20, then consider the renal failure for cause of high anion gap metabolic acidosis. If our GFR is normal and anion gap more than 20, then and osmolar gap is high, then consider the toxic ingestion. If osmolar gap is low, then consider the other rare etiologies like 5-oxoprolinemia, D-lactic acidosis, and late presentation of methyl methanol toxicity. Then we'll see what are the causes of high and gap metabolic acidosis. So it could be because of increased acid production like lactic acidosis, ketoacidosis, decreased renal excretion like severe renal dysfunction, drugs and the toxins like salicylate, ethylene glycol, propylene glycol, and methane. Then approach to NAGMA. So now we will see how to approach non-anion gap metabolic acidosis. So if we have calculated anion gap and if it is a normal, then we need to see whether the patient has history like profuse diarrhea or whether there is a history of large quantity of normal infusion. If it is yeah, if the answer of this question is yes, then the non-renal causes of NAGMA is like. If the answer of this question is no, then we need to calculate the urinary anion. How to calculate urinary anion gap? So urinary sodium, for that we need to find out the values of urinary sodium plus urinary potassium and urinary chloride. And the formula of urinary anion gap is sodium plus potassium minus chloride. So if this urinary anion gap is less than 150, then it is then there are two causes. Like it could be distal RTA or it could be type 4 RTA. So how to distinguish whether it is distal or that is type 1 RTA or type 4 RTA? So for that we need to see what is potassium. If it is hypokalemia, then type 1 RTA. If it is hyperkalemia, then type 4 RTA. So if the urinary anion gap is more than is more than 150 or more than the normal range, uh, then we need to consider non-renal causes or it could be type 2 RT. So for that, we need to evaluate other signs of the proximal renal tubular defect like glycosuria, amino acid urea, or phosphaturia. If it is there, then there are chances of the type 2 proximal RTA and we need to do the further evaluation. Now we'll see what are the causes. Like external bicarb loss, causes of NAGMA, like external bicarb loss, that is severe diarrhea, intestinal pancreatic fistula, ureteroileostomy, ureterosigmoidostomy. Proximal type 2 renal tubular acidosis is like paraproteinemia, like multiple myeloma, light chain acidosis, amyloidosis. Drugs like carbonic anhydrase inhibitor, calcineurin inhibitor, then toxins like lead toxin, mercury, copper, cadmium, kidney transplantation, paroxysmal nocturnal hemoglobinuria, Sjogren syndrome, vitamin D deficiency and resistance, inborn error of metabolism, like Wilson's disease, galactosemia, cystinosis, genetic mutation, like genes coding for sodium bicarbonate cotransporter, carbonic anhydrase 2, then distal type 1 renal tubular acidosis. It includes autoimmune disorders like Sjogren syndrome, rheumatoid arthritis, SLE, hypercalciuria like hyperparathyroidism, idiopathic hypercalciuria, and hypervitaminosis. Drugs like amphotericin B, tauline, lithium carbonate, foscarnate, ifosfamide, and ibuprofen, and genetic mutations. Then type 4 renal tubular acidosis is hyporenemic hypoaldosteronism, like diabetic nephropathy, chronic interstitial nephritis, IgM monoclonal gammopathy, and HIV. Then aldosterone deficiency like Addison's disease and 21 hydroxylase deficiency, aldosterone resistance like obstructive uropathy, lupus nephritis, sickle cell nephropathy. Then drugs like spironolactone, eplerenone, AC inhibitor, angiotensin 2 receptor blocker, NSAID, heparin, and calcineurin inhibitor. Then dilutional acidosis like resuscitation with large quantity of normal saline, total gut irrigation using normal saline, therapeutic plasma exchange with 4% albumin, and cationic amino acid containing total parenteral nutrition solution. Then loss of potential bicarbonate like recovery stage of decay and alpha lactic acidosis, voltage dependent renal tubular acidosis like urinary tract obstruction, lupus nephritis, and renal amyloidosis. Thank you guys.